35-year-old female. Patient presented to the emergency room with disorganized thought process, right? You have hallucination, some delusion. And then catatonic features on assessment, right? I feel like it's going to, she said she's planning a trip to space. And so that's why she's so busy, can't take care of herself. So clothes are like smell really bad. And then the body is basically unkept, right? What is your diagnosis? This is a case for you. If you see this, what should be your diagnosis? What do you think? This is a patient, 35-year-old female. She's in the emergency room with those features. What do you think is going on with that patient? Do you think is your differential? And what do you think you made the diagnosis? Do you think this patient has a bipolar? So your differential diagnosis, right? Is he a bipolar patient? Is he a schizophrenia patient? Is he a patient who just have a delusion thought, right? Or he's just a depressive patient. So these are your possible choices. What do you think is wrong with this patient? And how will you be manage this patient? These are the patient problem. Do you see anything in the history that make you pick that specific diagnosis yet? I always try to teach you to think when they give you a case, they've given you everything that you need. There's no ambiguity in NCLEX question, right? So these are, I summarize it. If this is your test, this will be like 4 paragraphs, but they will put those buzzwords. I call them buzzwords. I put them together. So when you're reading it, you're looking for them. Disorganized thought, right? Hallucination, delusion, and catatonic features. And this is just confirming those information. Like she's delusional, she has hallucination and disorganized thoughts and catatonic features. These are what kind of symptoms, right? These are symptoms we call positive symptoms consistent with schizophrenia, right? So if I give you a question and say, hey, which of these are positive symptoms, you know that disorganized thought is one of them. These are positive symptoms. Hallucination is one of them. And 3 is delusion. Catatonic features are negative symptoms, basically. I call them depressive symptoms, basically. They can stay in one place and they will never move. You can put your hand in one place and the hand stay there forever, right? So those are things they like your body, like you to pay attention to. Ovulation, lack of pressure, lack of desire to do things. They look like they're depressed, but they're not depressed, right? And the patient smell really bad, is unkept. So what is your priority for this patient? Priority for this patient. If this is the case, what are you going to take care of? What is your priority for this patient? Right. So the priority problem for this patient, what do you guys think? Is mostly physical need. Provide physical need for this patient. He can take care of himself. This patient will be admitted to the hospital and we'll provide physical need. Physical need, IV fluid, make sure we get them dressed and take care of them. Make sure they're getting what they need. And they will need some medication. antipsychotic, try to stabilize them, right? Remember, after you provide a physical need, so you get some, we got to bath him, right? He's not eating. So maybe some nutrition for this guy, food. You get some IV fluid, yeah, we can let him take some bath and give him some more clothes. We shave him if we have to shave him, and then we deal with their psychological need. Their psychological need is, what is the strategy? What is your strategy of psychological need? So the diagnosis is schizophrenia. This patient has schizophrenia. And so what is our strategy for psychological need? To ask you is one-on-one. You, the nurse, you are the initial therapy. So one-on-one with the nurse until they're talking to you, because he has catatonic feature, it does not want to talk to anybody. It does not want to talk to anybody. If you put him somewhere, he will stay there to 24 hours. He will be there. So you are the one, the strategy is you are the one. You bath him and you do one-on-one talking. If he's not talking to you, he's not ready for group therapy. So if you see group therapy, just don't pick it. Group therapy is a trap, okay? Don't pick it. This is a trap. Until they talking to you, until they laughing with you, until they nice with you, they don't go to group therapy. They don't go. After they talk to you, they're happy with you, high five and everything, then you send them to group therapy and they start getting better and better and better. We've taken care of him. Now we got to stabilize him, right? We have to stabilize them. What are you going to use to stabilize them? What are you going to use to stabilize them? You need some antipsychotics, right? So you have two options. You have the first generation versus the second generation. Right? Which one you want to choose? You need an antipsychotic so that we can put it on medication. There's a strategy. Okay, so for schizophrenia patient, when they are hallucinating, don't argue with them and don't reinforce the hallucination. Okay, don't reinforce it. Don't ask questions about the hallucination. So don't reinforce it. The only time you're going to ask about it is if it's auditory. If they tell you they're hearing something, you have to find the content. Find the content. You said, what are you hearing? What are the voices telling you? Find the content of the hallucination. That is the key. Apart from that, if it's visual, if it's tactile, yeah. And if it's you just basically, you don't ignore it, you acknowledge it. The key word is acknowledge whatever they're telling you, but you bring them to reality. That is the key. So I'm going to acknowledge it and then bring the patient to reality. So I will acknowledge this. I will acknowledge this problem, then bring them to reality. Say, hey, I know you're seeing something on the wall. I know something is crawling on your skin, but I don't see it, Mrs. But this is what I see. Okay, it's because of your underlying problem. We're going to take care of you, but you acknowledge it, but you don't ignore it. Say, hey, there's nothing there. I don't see anybody there. I know it's disturbing you. This is what you see, but I don't see that. That's how you handle their problem. Now, we put them antipsychotic. You got to put them antipsychotic. So that's either first generation, just second generation, whatever you decide to give them, it's fair game, right? So, assuming we decided, let me pick this patient, Aripiprazole. This is what she's going to go on with. Okay, what kind of antipsychotic is that? What generation is that? So it's a second generation antipsychotic. Okay, so second generation. So this is a second generation antipsychotic. And one of the common side effects is weight gain. Most of them, it's like weight gain, hyperlipidemia, and diabetes. Most of or hyperglycemia, basically, does. Most of the second generation antipsychotic will cause that. That is the most common side effect for this condition. For 3 months, okay? She's complaining of what? Excessive weight gain, over 20 pounds, I would say 10 pounds. In 3 months, she's not happy, right? She's still not happy. And when we check a finger stick, random finger stick, it's like 200. Is that good? Random finger stick is 200. What do you guys think? Is it a good thing for this patient? So the sugar is too high, and therefore they decided to put the patient on 2 medications. You have choice, Metformin. I'm making it as we go, so just bear with me. Metformin, this is Glipizide. Which one do you want to choose? It's a female, gained 10 pounds in 3 months, and then a blood glucose, let's make it random glucose greater than 200. So maybe 250. And then we said it's too high, and we decided to give a metformin or glipizide. Which one would you choose? And the pathophysiology of that disease process. What is this patient problem? Weight gain, 10 pounds. And she's taking medication that is causing that. You want to give her something that does not cause weight gain. And what is that something? Is a concept. Anything that stimulates insulin released will lead to weight gain. So, which one causes insulin release from the pancreas? If you causes insulin release, you're going to cause weight gain. So we should not give her something that will stimulate insulin release from the pancreas. And so this is the pathophysiology. Glipizide causes insulin release from the pancreas, and therefore it causes weight gain. So we should not give her a glipizide. So best choice is metformin. So that's the problem. We got to choose metformin for this patient. That will help with the weight gain, and that will be a best choice. So if she is struggling with weight, we should give her this one. So that is the concept over there. Okay, guys. Now, they decided to get a CT scan of the abdomen. So we got to get a CT scan. And she's been taking metformin for 3 weeks. What are you teaching? So what are you teaching? She's going to take metformin, and now she needs a CT scan. What are you going to say? So somebody say off of it for at least 24 to 48 hours, and then we can get a CT scan, and then after you wait for 24 to 48 hours. So that's the strategy to pay attention to. Why are we doing this? What is the reason why we have to do this? Wait for 24 to 48 hours. Lactic acidosis, excellent. So you guys acing the test, you know. If she developed lactic acidosis, how do you think she's going to compensate? I developed lactic acidosis. What on physical exams, what are you going to see? Anywhere, but like we're connecting system to system, compensation of lactic acidosis. How would you do that? How do you do that? It's a metabolic acidosis. So the key concept is respiratory what? Alkalosis. And what is respiratory alkalosis? Hyperventilation. So you'll be seeing this patient will look like a DKA patient doing Cushing breathing, deep respiratory in order to get rid of the acidosis. So she will be hyperventilating as much as possible. So hyperventilate. Remember, your board will give you this, and don't forget metformin. Common side effect is GI symptoms. Don't worry about it. You have nausea and vomit. It's okay. That's not a priority. That is what I call B sharp. You should not let this confuse you and pick that answer. It's not a B sharp moment. Nausea, vomiting because you take metformin is not a priority. It's a common side effect. So for every medication, pay attention to the common side effect, but ignore it and go for the jugular. The jugular is lactic acidosis. You let them stop the medication 24 to 48 hours before they do that. Did that, everything is perfect. She had a CT scan. And then all of a sudden, she came into the clinic, okay, and she started complaining. Saying that she's been pacing all the time and she can't stay still. Inner feeling of restlessness. And then she been pacing in a room, pacing nonstop. And then sometimes fidgeting, just this, and a pacing nonstop. What do you think has happened now? The kid has inner feeling of restlessness, and she's like cannot stop moving, and she's screaming for you. Just help me, doctor. Help me. What do you want to do? And they give you these questions like that. Be careful. Don't pick the broad one. I know this is extra EPS, but EPS has a bunch of it. You have acute dystonia, you have akathisia, right? You have Parkinsonism. Parkinsonism. And you have tardive dyskinesia. So you got to, this is specific symptoms. EPS is not enough. You have to break them down, right? You have to break them down. So you got to break it down and see which one she's having. So I'm giving you a bunch of content. So this is akathisia, inner feeling of restlessness. How will you treat this patient? Treatment. How will you treat this patient? So yeah, beta blocker, propranolol, anticholinergic. You can use benchtropine, but beta blocker is number one. You can also use even diazepam, muscle relaxant. It will help with that. The inner feeling to calm them down. Okay, then you can give them anticholinergic to help with that. Okay, so that's the management of that problem. During that time, when she has inner feeling, she keep on running around, and then she fell. Okay, fell and broke the leg. Left leg, left ankle. Right? She broke the left ankle. And now she has crutches. I have crutches. I broke my left leg. Teach her how to walk. Somebody say advanced crutches and affected leg together and unaffected leg together. Okay, I take that. So that's what your contribution from your class. So affected in the crutches. Then unaffected. So that's the tripod position, right? Okay. What kind of specific, how does she hold the crutches? How far the crutches go? What do you think? What kind of other things you want to teach this patient in terms of the crutches? So the elbow should be flexed between 20 to 30 degrees. Okay. The crutches should be 6 inches on the side and in front. It's okay, so 6 inches side and in front as much as possible. And then need at least 2 to 3 finger breadth between the armpit, right? And the armrest. Okay. And then bear weight on the hand. Okay, not the armpit, on the arms. So that's what you tell them. Okay. So that's what you teach this patient to. Okay. They check because of the hyperlipidemia, they do a lipid panel, right? And LDL it's like 200, right? The HDL is like 20 and then 30, 35, and the total cholesterol is like 350, and then triglyceride 200, 135. Where do you want this to be? Do you think this is enough? What numbers do you want it to be? So cholesterol, we want it to be less than 200. Yeah. So we want the LDL to be less than 100. So this should be less than 100, right? And you want this, if she's a female, so at least greater than 50, 45 is good. You know, I'll put 45 there. And then total cholesterol less than 200. And then triglyceride less than 150. So what would you put it on to fix this problem? You put it on statin. Okay. What teaching do you provide? Diet. Somebody said low-fat diet. But that is not specific for starting, specifically you got to teach them, take it at night, right? Take at night. Report muscle cramp, right? No grapes juice, right? No fruit juice. And what else? There's one more. Call 4 weeks later with dark urine, right? Dark urine, muscle cramp, and you get a CK, it's like 20,000. 20,000. What has happened to her? What other lab work do you want to get? So she's developed rhabdo. Now we have rhabdo patient. Rhabdo. What lab work do you want to see? And probably it's elevated. We get creatinine. LFT is fine, but that's not. Get a potassium. Potassium is going to be, so BMP. So I guess you will get it from it. So potassium is very important. What is the management of rhabdomyolysis? Flush them out. Flush the hell out of them. Okay. So IV fluid, IV fluid, IV fluid, IV fluid, IV fluid. Then you give them furosemide. Okay. They have to be in a at least cardiac monitor because of changes of the hemodynamics that can happen. Okay. Until you correct this problem. But it's they may have problem with renal failure. You give them, they may need dialysis. You got to control the acidosis. So it's very, very important. The kidney is being damaged by IV fluid, IV fluid, IV fluid, and then you flush them out, okay, as much as possible. So that's how you manage a patient with this problem. You see, we fixed it, but we broke her also. Let's treat the K. Treat K. What is your management of hyperkalemia? What are the things you do for it? Number one, calcium gluconate, excellent. So protect the heart. You get an EKG, make sure so you get calcium gluconate. You get IV, insulin, and glucose, right? Or D50, whatever. You get them K isolate, right? Fine. You can give them furosemide, so laces, and all these things will take care of the problem. Unfortunately, she came to the emergency room with ECG. She came back 4 weeks later, okay, with what? Vaginal spotting. She has right lower quadrant pain. And the ECG is positive. What is your diagnosis plan? ECG positive. What is the problem? Ectopic pregnancy, ultrasound ectopic pregnancy, excellent. Ectopic pregnancy. What is your plan? How are you going to manage this patient? So now what is your plan now? We know we have a diagnosis. What is ectopic pregnancy? Ruptured ectopic pregnancy. So this is a key, okay? Don't let them trap you. Please don't pick the answer. Methotrexate is designed for patient who does not have potential for rupture. They come in, everything look fine, no pain, you get an ultrasound, hey, they have ectopic, everything is good, they have no pain, nothing like that. Yeah, those are the ones we give you methotrexate. It's not designed for those who suspect there may be rupture. Don't get trapped. It's used for those we don't think. This patient will need surgery. But what do you want to do? You can't just take this patient to surgery, right? Potential rupture, fix them, right? Don't every time somebody needs surgery, MPO, IV fluid, type and cross, okay? All these things, need an antibiotic, just make sure they're ready for surgery, okay? You can't just drive them to surgery and then they're going to get sick. Prepare them. All this is indicated before you take this patient to surgery, okay? As much as possible. And don't let them trap you. So prepare them, stabilize the patient first, and then cross-match them, and then you take them to surgery. Okay, So patient has successful salpingo-oophorectomy. That's the name. It's a basically, or they can do salpingo-ectomy, open the tube, take the ectopic pregnancy out, depending on how bad it is, and it will be good. So we saved that patient, right? We saved that patient. Assuming the same patient, she was pregnant. We found out she was pregnant. She was in the emergency room, right? And she has vaginal spotting. And she complained of painless vaginal bleeding. There's no pain. There's no pain. Okay, so what do you want to do? It's painless. What else do you want to do? So we're going to do ultrasound. What kind of ultrasound? And then we saw the finding. So we have abdominal ultrasound. And what we find that the cervical, the placenta is covering the cervical os. What is your diagnosis? That's Previa. If that's Previa, what is your plan then? Plan. You say placenta Previa. So you, the nurse, what are you going to do? Plan of care. I will start. We need to type and cross these patients. No vaginal exams. Okay. We check their pads. Okay. So we got to do that. Check their pads, no vaginal exams, and monitor their vitals, right? Everything was perfect. She did well, no problem, right? And then the nurse said, hey, a new graduate came in and I wanted to know, saying that, hey, I heard about something, you know, can you teach me? So she drew a line and then she put maybe Previa here and put Abruption here. And then he put Rupture. Right? And he said, okay, what is the difference between them? Painless bleeding, painful bleeding, tachycardia. Loss of fetal station. Right? Fetal bradycardia. Fetal D-cell. Right? Emergency surgery. Okay. So just help these new graduates to pass the NCLEX because she heard about it. She been worried about it. So she want to know, I mean, what is the difference so that she can pass the NCLEX? They say, somebody said 4 is Rupture. So 4 is said it's Rupture. Somebody said painless is Previa. Painful is Abruption. All of them are bleeding, so they can have tachycardia. Just know that. They are bleeding problem. Emergency surgery. Most of the time, the Previa, there's no bradycardia, there's no D-cell. There's two who have this problem. So this is the way it will look like. They put her on steroid for no reason. She takes steroid for 3 months, right? All of a sudden, she's gaining weight again. right? She have asceticism. What other symptoms do you expect? So some people say insomnia, hyperglycemia, osteoporosis, hypertension, hypernatremia. What else I see over there? Buffalo amp. Acne, risks of infection, fever. That's what people are saying. I don't know about fever though. Okay. Central obesity, moon phase, abdominal. Excellent. You guys ace it. And the last one, then I can go. I can leave you guys. And I can't do this anymore. Last one. Look, she said, well, I don't have Cushing. I have Addison disease. List 4 things that is only found in Addison. 4. Only found in Addison. Pigmentation. Bronze pigmentation is the same thing. Abdominal pain. Vitiligo, weight loss, hypoglycemia, hyperkalemia, where okay, that is enough. 1 hour, just 1 hour. You see what I've done to you. Sorry. If it's too fast, sorry, but the fast pace, quick learning, you know. If you need something, if you have questions about adapting class, just email me adaptingclass@gmail.com. You know,